All right. Hello and welcome back. I'm Eric Sunset, your host of the Doc Buddy Journal. And today we're joined by somebody who really needs no introduction, and that's Scott Becker. Scott is the publisher of the Becker's Healthcare portfolio of publications. He's also a partner at McGuire Woods in Chicago, where he provides counsel to all types of healthcare organizations and a variety of healthcare industry entrepreneurs. Scott, thanks so much for joining us.
Eric, what a pleasure. Thank you for having me. Looking forward to visiting with you and just to enjoying our time to discuss healthcare and business and everything together. So thank you very, very much.
It is absolutely our pleasure. And just, as a quick programming note, it's hard to believe that this year's run of events is already behind us, but you'll be able to see both Scott, the Becker's Healthcare crew, as well as Doc Buddy at some of the upcoming events in 2025 in Chicago, of course. So we're looking forward to that. And I know the sort of the basis of our conversation today revolves around healthcare. What's hot in healthcare, the news, what are people talking about? And a recurring theme, sort of about this time last year, it started to heat up, and that's around AI in healthcare. And that has for sure been the hottest topic in the news and on your sites. So, Scott, from your vantage point, what are you seeing the evolution of AI in healthcare become?
Sure. No, I think it's a great, great question. And we break it down into two different ways: clinical versus administrative. The use cases, where it's most useful, where people are finding it useful, and then of course that will evolve greatly over the next several years. I mean, if you think about the iPhone 15 years ago, no way in the world we would have thought we'd have all these different use cases and apps for it. I mean, almost it may be predictable by some, but unpredictable by the rest of us. So what I'm sort of looking at is I break it down first into clinical versus administrative. The earlier use cases, the most present use cases so far, have been more along the administrative side than the clinical side. But some of those are sort of a very hybrid type of thing. So the biggest early use cases were in things like revenue cycle, predictive analytics, managing of ORs, managing of revenue cycle. In some place where you could replace repetitive tasks that were being done by humans that were very hard to even find or employ, particularly during the pandemic, where there's just tremendous shortages of people. So you saw lots of movement quickly. We're on the 30-yard line out of 100 yards in the administrative side, or maybe the 20-yard line. But then on the clinical side, you're just starting to see use cases where you talk to physicians, you talk to leaders, and they're actually seeing real value. And one of the examples I hear about regularly, I don't know if it's a sponsor of ours, I don't think it is, I just don't know, is GI Genius. And GI Genius is a software that people use in AI that applies AI to colonoscopies that improves the find rate, for use of a simple term, of polyps when people are doing colonoscopies. And I do hear from gastroenterologists that this is actually quite helpful. Not everybody, but largely, not replacing gastroenterologists, but improving their outcomes. And I think you'll see, there are so many different places where you'll see some of this, whether it's in surgery that's digitally assisted, robotically assisted, where a person just has not really AI, but better vision into what they're doing. And so I break it down into two big ways: clinical versus administrative. And then the second thing I break it down into is 2x versus 10x solutions. And when I talk about 2x technology solutions, I think about things that amplify and leverage our physicians' time, our nurses' time as they are. So very helpful, but not what I think of as game changers. So telehealth would be a great example. It doesn't replace physicians, but allowed physician work to be done from multiple different locations without having to be in person. And sort of the earliest test cases or use cases for telehealth were in radiology going back a long time ago, just because you couldn't get radiologists to lots of small communities. So radiology telehealth was the first mover in sort of that area. When you see those types of things, they don't eliminate the need for the physician, but they might make it more accessible, easier to access, better able to manage. And the great challenge is I'm going to give you a much longer answer, of course, than you wanted, Eric, so bear with me. The great challenge we've got is 1,060,000 physicians in our country, half of them going part-time by 40, and 340 million people, and that aging, growing population. So the numbers are the worst ratio we've had, I think, in a very, very long time, and getting worse. So the 2X solutions are good, that free up physician time, the ambient listening types of things, the things that free up some of their time and maybe avoid some burnout and allow them to do a little bit more or take more breaks. Very helpful. What we ultimately need is the 10X solutions, like what you're doing in AI with revenue cycle. AI is replacing in a lot of places what a person was doing. And we're some time away from, in different specialties or primary care, having AI truly either replace or leverage the physician's time a million times better, so we don't need to have 2 million physicians, which we're only producing 25,000 a year, so we'll never get there. So we got to figure out a way on the clinical side to get from these 2X solutions to 10X solutions, and I think we're a long time away from it. And it doesn't mean that we'll be replacing physicians. Every time we've improved technology, we've never really replaced anybody, but it provides different opportunities and need to figure that out. But we're some time away from having the impact we really need to solve the biggest problem we have, which is not enough providers, specialists, primary care physicians. The AI use case for primary care is abundantly clear in getting close, where you could use a PA to do a lot that a primary care used to do. You know, you could use a CRNA to do a lot that a anesthesiologist should do. There's lots of places where the AI can help a great deal, and the intelligence, the analytics can help a great deal, but we're still a far way away from that in a lot of specialties. But that's the frontier that we'll either have to get to or we'll get crushed as a country in terms of these physician and staff shortages.
You hit on a topic that's near and dear to me, and that's on these physician shortages driven by burnout. Obviously, healthcare-centric sites like yours, they're reporting on this precipice. We're on the precipice of a cataclysm with having the right number, or even nearly the right number of providers to treat patients in the US, but that is not something that's being talked about on your cable news networks, at least not that I've seen. So I wholeheartedly back the sentiment that these 10X solutions, whether they're AI or not, something needs to be done, because the amount of administrative tasks that we're burying providers under is killing the job.
Right, and what you're talking about, what you mentioned, that's exactly the right on point, is that people have talked about for years this political football of Medicare Advantage, Medicare for all, coverage, needing coverage for everybody, and I think most of us agree at this point, whether you're a Republican or Democrat, that we want to have coverage for everybody. That, I think most people don't have a huge argument over that. It's figuring out how we do that. But then coverage is very different than access, and getting access is the great challenge that's evolving, you know, particularly outside of the top 10 to 20 big metro areas. The access problems are just incredible. They're very challenging in the big metro areas too. Like if you want to get to the right person, you know, you need to know somebody, and that's obviously a horrible statement for health equity. It's just a horrible statement for where we're at. And we've got multiple different trends going on. There was 4,000 additional residency spots, which again is a drop in the bucket that we're going to be funded in one of these different bills that was on Capitol Hill. But of course, it gets packaged in like everything does into huge, gigantic bills that didn't get passed. So you got the shortage of residency spots. You've got a situation where growing populations. You've got a mismatch of specialties to needs. You've got enough people going into orthopedics. Not nearly enough people going into a ton of other subspecialties where you really need really bright people and so forth and so on. We've got, for the first time that I remember, we're working towards a serious shortage in GI, which I didn't think was going to happen. We've got about 14,000 gastroenterologists in the country, and now we're looking at shortages there. You know, a lot of different places. I recently had a horrendous summer for my own health. The beauty of healthcare is we're all consumers. I had a detached retina, I had to have that replaced, and I had to have cataract done, which is a direct follow-up to having a detached retina. And what I find amazing is how hard these physicians are working to take care of their patient base. I mean, it did this cataract on Friday. The doctor comes in by himself on Friday, on Saturday morning to have a follow-up visit with the 7 patients he saw the day after Thanksgiving. And just like the guy is working his butt off, and bright guy, but I can't imagine that's not a prescription for burnout. No staff in the office, nobody helping, just him taking care of 6, 7 patients to work through the follow-up from the day before. And it's amazing that he's got that yeoman's effort to do it, but that's a hardcore. That's hard work. And that's just a very, the beauty of healthcare is every single one of us is a consumer. So you go in an ER today, they're swamped. I mean, they're just swamped. I mean, wait times are 3 hours and 45 minutes. Just 10 years ago, people were advertising, we'll get you into our ER in 30 minutes. Now those advertisements are all gone. But just a tremendous shortages throughout the system. They're getting worse and worse. Medical education's broken. I mean, we're still educating physicians by the sort of method that was built 100 years ago before the internet. It just is literally with lots of rote memory, lots of everything. It's an insane situation, and we've got to fix it.
We definitely need to fix it. There's some macro items that we can potentially tackle. There's some more micro items that things like health systems and medical schools can help to tackle. To go to that macro layer, some of the other big news that really just happened is, unless you're living under a rock, you'll know we just had a pretty major presidential election. We get Trump 2, we have a GOP House, a GOP Senate. What are you hearing that might be different going into January 20th, 2025?
Yeah, this is a great question, and it's bifurcated. When I look at the Trump administration, the first one, I think that they and a lot of other people got it wrong on placing such big bets on Medicare Advantage. I'm not a fan thus far. I think it's been a huge boon to the payers. Patient satisfaction is lower with it. It's costing the government a lot more than expected. It's like everything else. All we did was add a middleman, a middle person to the Medicare program, which is one of the most beloved programs in America. So I think Trump, one, got that wrong. Biden came into office against it, but then, of course, got talking to by the insurance industry, became a fan of it, and sort of they both ended up down the path of being very pro Medicare Advantage. And to me, that is just it's a horrendous program. And I know people disagree with that. There's people, the idea of it may make sense, but you have to take out reality to get to that point. The perspective is there's a canon of thought that's become almost like religion, that fee-for-service is bad, that it leads to some abuses, and no question it leads to some. But the same canon of thought and narrative should be applied to managed care. The idea of it, that we're going to manage people's care in a value-based way, of course that sounds good. The reality is that you have just as much abuse on that side as you have on the other side, and that abuse was horrific during COVID. Medical loss ratios went way down. Insurance companies, Medicare Advantage providers got rich, but for all the wrong reasons. Not because they were managing care well, because procedures and screenings weren't being done because people couldn't do them. So everybody cleaned up, but you have abuse on either side. I'm not a believer that it's the payment system. I'm a believer at the end of the day, it's a supply and demand issue, which we've talked about some already. So the one thing I think the Trump administration got very wrong the first time was they're buying into the insurance companies' love of Medicare Advantage. The thing that they got right the first time around was expediting and streamlining so many processes at the FDA and other places. They just got that very, very right. I don't know if they'll get it right this time. I mean, obviously, like, I'm not one of these people that's an anti-Trump or at any cost by any means at all. I do believe he got some of his picks so far right, like Marco Rubio's fine, Elise Stefanik's fine, a lot of people that he's appointing are fine. Dr. Oz, to me, and I don't know Dr. Oz, I've not met him, I've watched his career, of course, like all of us have. He became like a healthcare hustler. I mean, he became like an embarrassment to healthcare over the course of his career. And there's things to like about him. I mean, he's a driven guy, he's a charismatic guy, but at some point he crossed the line from being a true doctor to being sort of like almost a joke of sorts. And he's a huge Medicare Advantage proponent. And one of these people are Medicare Advantage proponents. It's not that it's, the truth on all these things is always somewhere in between. So, but I'm not a fan of, some of his perspectives as to Medicare Advantage. I just think all these things sound good in theory, but they don't necessarily work. All they end up really doing is they added another layer of tax to our system, which is just a whoosh to the insurance company. So I've not been a fan of it. I don't like Dr. Oz's views on it. I don't have great regard for Dr. Oz, but I don't know him that well or that deeply to really have a great feel for it. Robert F. Kennedy, I don't know enough. I always thought he was such a quack. And then, of course, he's now going to be in charge of something big, and it's fascinating. It's not like, and he's not wrong in some of these thoughts, not right in some of his thoughts, but I'm not, at least from this perspective, I'm not fans of some of those picks. Now, but to be fair, I also thought Joe Biden in certain areas had some horrendous picks for his leadership. Some horrendous political hacks that ended up in charge in the Biden administration. I'm a huge fan. I think Anthony Blinken's done a great job in the Secretary of State role. I think Janet Yellen, Department of Treasury, was a well-respected person who over the course of her career became a total political hack. So, I don't, like saying, oh, the inflation's transitory, it's not going to be a real problem, it's not going to be a real issue. It's just talking points out of the DNC at that point. So I think, some of the Trump picks, I don't love the Oz pick. I don't love the Robert F. Kennedy pick. Some people do love him. I don't know him well enough to really have a feel for it, but enough what I see gives me concern. And we'll see how it goes. We'll see how it goes. But I'm not, so I think they'll probably get the FDA maybe a little bit better than the Biden administration got back to being really slow on it and horrendous. The Trump administration was pretty good on the FDA. The Trump one, FDA good, Medicare not so good. Free market, somewhat positive, but so much of that free market's not really a free market anymore. So I think it's a mixed bag. But I'm not a fan so far of the Mehmet Oz pick or I am a fan of the Elise Stefanik pick. I am a fan of Marco Rubio's fine. It reminds me of a modern day John Kerry. He's fine. But I'm certainly not I don't start off loving RFK's views on a lot of stuff. I do, and Dr. Oz, I think, has become sort of a drugstore hustler. I don't really know how to describe Dr. Oz today compared to what he had built years ago as a reputation.
Yeah, well, a lot remains to be seen, particularly with the folks you identified. One thing that I'm hearing will be slightly different from Trump 1 is that Obamacare, the Affordable Care Act, maybe won't be so much in the crosshairs this time around for the point that you made. Getting coverage to people, I think, is a more reasonable stance, and it's not just coming from the other party that installed Obamacare, created the Affordable Care Act.
Yeah.
So it seems like there'll be maybe some fine tuning there, a little restructuring there, but certainly not taking a chainsaw to it.
I think the bigger issue, and this is something that Trump has in his favor, that there's some tailwinds he has on that are negative and positive. So the big tailwinds are Joe Biden, both Biden and Trump were horrendous presidents for the federal deficit. And I'm a federal deficit watcher. I view it with great concern. So they were both horrendous on the federal deficit. And this year, deficit's $1.8 trillion, which is horrendous. By anybody's measure, it's horrendous. It's 8-9% of the economy. We're getting 2-3% growth. That means we're throwing away 5-6% someplace. It's literally having that kind of deficit is horrendous. Trump is going to be the beneficiary of some of the things that were added into the America Rescue Plan, the ARP, fade away by themselves in the next year or two. And a lot of those are Affordable Care Act subsidies that helped make the Affordable Care Act continue to have pretty good coverage and get our uninsured rate down to about 10%, but also cost the government a fortune. So Trump, without taking the chainsaw to it, without having to do anything affirmatively, those subsidies are going to wear off, and I'm sure that he and Vance and team are going to largely let them wear off unless they get so much lobbying from the insurance companies that they don't. So that's going to bring the deficit down some couple $100 billion a year without him doing anything and getting what some of the far right Republicans wanted, which is less of this Obamacare Affordable Care Act. So it's a fascinating situation. I think the Affordable Care Act, I don't start off originally as a proponent of it, partly because how it got passed, but at the same time, I'm a huge fan of the fact that we're able to move down our uninsured from 20 to 10%. And now we've got to deal with the real problem, which is access and enough providers, enough supply. So So we'll see how it goes. But I think it's a fascinating set of subjects.
And with the Affordable Care Act, you're going to be right back sort of where you were on day 2 of it. Yeah, we got a lot more people coverage. They can't use it, but they're covered. They have insurance. So
Well,
we'll see.
that's right.
Lot remains to be seen there.
That's exactly right.
And one of the other pieces of news, sort of heads and tails of that run up to the election week, was the CMS 2025 final payment schedule. I know across your sites you've collected a lot of reactions from individuals in the front lines of healthcare. I haven't seen a whole lot positive on what was published by CMS. What's the silver lining, Scott, if there is one?
Yeah, I don't know if it's so much a silver lining. It's the great challenge. Physicians and health systems are caught sort of in this very in between spot where they used to be so reliant on commercial payers to subsidize what they made in Medicare and Medicaid, and now we're in a spot where they no longer get that subsidy from commercial payers because a larger percentage of the population is through Medicare and Medicaid than it's ever been. So not only is half of Medicare Advantage, basically half of everything is governmental pay. And so you're in the spot where government pays a bigger and bigger part of it. What happens is providers at the end of the day gravitates towards liking the fee-for-service Medicare and Medicaid pay, not necessarily the reimbursement amounts, but they've grown to understand the system and they get paid and they don't have all the pre-auth and denial types of situations. So if there's a silver lining to it, they're going to go up less than inflationary worth of inflation, which is bad, but it still is a stable program, and people don't get screwed with under the Medicare and Medicaid programs as much as they get screwed with, meaning providers and health systems, as they do under Medicare Advantage. So if you want a silver lining, that's a silver lining. The challenge is we've got a horrendous federal deficit problem, and it's going to get and Medicare Advantage feeds more into that versus less. So it's a debacle. Yeah, I don't have a silver lining. I think it's sort of like at the end of the day, we've just got to continue to strengthen the healthcare workforce and make sure we've got enough of a healthcare workforce while adding technological sort of advances too. But there's no real silver lining. It's like health systems, out there 50-50. Half the health systems are making money, half of them are losing money. You've got closures again going on, and that's outside of sort of the private equity funded stuff that got messed up through too much debt. Just in the general healthcare community, you've got big systems struggling, still, and some systems doing fine.
Well, one thing that I'm really interested to watch, we have a lot to be watching for next year, and I'm certainly not a part of the RFK Jr. cult. Cautiously optimistic about what maybe he can do around the ownership of an individual's health, because we've talked about value-based care a little bit. Let's keep healthy people healthy. Let's keep them out of the emergency room. Let's keep them out of the hospital. So his whole "Make America Healthy Again" sort of mantra, we'll see what happens. We'll see what it takes. I know there is a subset of society that is really bought in and really excited, and maybe doesn't need that encouragement because they're already.
Yeah, no, I think the challenge is, of course, I am getting older, of course, and so of course, as you get older, you spend more and more time on your physical and mental health. You have no way around that. If there's this great concept, Peter Attia writes about it a lot, the health span versus lifespan concept, that if you live to 84, you want to be as healthy as possible to 79, 82, so your last few years aren't just horrible, and so, the problem with the RFK thinking on this stuff is China and India both had to gravitate towards preventive care models because they're just so understaffed in terms of physicians to population. This is the fallacy. I'm going to go through this RFK thinking on Make America Healthy. All of us are believers that if on average our country lost 10 pounds apiece, we would cut down heart disease, cancers, orthopedic issues, joint issues, probably inflammation issues, and everything. So on average, if we all lost 10 pounds, that would be a win. What China and Russia taught us during the pandemic, both those countries are heavily reliant on preventive care models by necessity. They don't have enough doctors, healthcare workers, and labor force. China, because they're so short of people to take care of people, had to close down entire swaths of their economy during COVID because they had no one to take care of people. India ended up in periods of time in the same exact issue, and I don't blame them. They have a billion five people in those countries, a billion three to billion five in each country. I don't blame them. They don't have nearly enough providers, so India just got overrun during the worst parts of COVID, just overrun with people that couldn't be cared for. So what I'd say to RFK, oh my goodness, is like it's the same thing when people talk about value-based care. It's all nice in theory, but you better trust and verify in the back end. It all sounds good. Like RFK has maybe done a good job of getting this associated. God bless him. But the reality is, for most Americans, the willpower it takes with the food around us, the amount of sort of like the amount of where we're at as a culture, where we're at as a community, it would be great if we were all healthier. I believe that, like when JFK had the Fitness Medal of Awards and we made it part of the bully puppet, absolutely. Do I think that bully puppet's going to really move us towards better health as a nation? I don't. It might move a few percent. I mean, you and I can get as many motivational videos as we want on YouTube, on any place we want to look at, on how to keep healthy. It's a war for me every day to keep my weight under control and be where I want to be. It just is. And it is for most people. You know, I mean, you might be fortunate. You look taller and thinner than I am. God bless you. I wish I was that, but it is what it is. It is a war every day. So when people say they're going to use their bully pulpit to fix our health, I would say if we weren't on a public podcast, I would say go blank yourself, because it's a great idea, but we better have enough doctors and nurses and people to take care of our people in case the experiment doesn't work. You follow me? India and China ended up trying to go that experiment and no choice, by necessity. And they got screwed because they don't have enough workforce to take care of their people. It just is like we're getting to have 340 million people. We're the third largest populated country in the world. We don't want to be those countries in terms of our healthcare system. And people talk about, well, we don't need as many doctors. You know, we had this, you know, and I've had Hillary Clinton in our conferences a number of times. I like her in person very, very much. But they were predicting when they were trying to move everything towards the insurance companies, and I guess it was the 80s or 90s, that we're going to need a ton less doctors, because everybody's going to manage care better. They were completely wrong that managed care would lead us to needing less doctors and nurses and people. This is the experiment that when I hear these guys talk about, well, preventive care is going to solve things. It's the same people that say technology is going to solve all of our problems. Technology is great, but trust and verify. We better get more doctors. We better get more nurses, better get more RTs, more technicians, more everything to go with the technology, to go with the preventive care. I don't believe the preventive care is going to solve it. We all ought to be on a GLP-1. I don't disagree with that, but even that's not going to get us where we need to be.
Hear you loud and clear there. Hard to argue with any of that. We'll test, we'll verify, we'll see what happens. We started off saying AI in healthcare was the hot topic for this year. Do you have a prediction about what we'll be talking about most in 2025?
You know, it's a great question, and I'm not sure. There's been so many changes the last couple of years, and I laugh only because I get so ramped up and start talking, and I feel like, oh my God, I'm gone off on a tangent, so I apologize. That's my reason for laughing. I apologize for getting so ranted up on this, but I think it's so insane, this concept that we don't need as many doctors and nurses and stuff like that. So if I spend a lot of time in the supply and demand of healthcare. In the top 10, 20 metro areas, it's not nearly as bad as in the rest of the country. But even there, subspecialists, specialists, we're in horrible trouble. So what are going to be the big issues going forward? It's very hard to tell. So a couple of years ago, the big concern for hospitals and health systems was the disruptors, the retail disruptors. And then, of course, the CVSs, the Walgreens, the Walmarts all got out of the business because not because it's such a hard business. Health systems would like to tell you, well, they got out of it because it's such a hard business. It's not such a hard business. It's a simple business. But to staff what they need to staff, they need enough people and bodies to take care of it. You can't have 5,000 drugstores and there's only a 1,060,000 doctors in our country, and staff 5,000 drugstores, whatever amount of Walmart outlets are, whatever amount of CVS and Walgreens outlets, they just can't do it. So at some point, supply and demand is going to hit a boiling point if it's not already there. You know, you go to right now, like when my elderly parents need to go to the doctor, half the time they can't get to the doctor, they need to see, so they end up in the ER. When our younger daughter, who's healthy and in great shape, you know, half the time when she's in trouble, we end up at the ER. Everybody's going to end up at the ER. You got 3.5 hour waiting times at the ER now, and I think at some point you'll hit this crisis point where people start to see, like you talked about, you hit it exactly right. Nobody talked about cable news this year about healthcare because there's so many other, I mean, reproductive rights, yes, but general healthcare, no. But we all know we've got this looming access problem. You have to be like out of it not to see it, or you just really sort of like, or you've always been in an impoverished area, and so healthcare's always been horribly impoverished. So you're like, well, it's always sucked for us because our health equity is so bad. But and we need to fix that. But if you don't fix supply and demand, health equity gets crushed, and sooner or later we all get crushed. So I assume that even though we'll be talking a lot about technological advancements, we're going to be talking about shortages for a long time because we're not really doing anything yet to address them in any serious way. So I think, I don't know when that's going to be the big issue. It's like a broken clock's right twice a day. At some point, that's got to be the big issue because everybody, I have access. I donate to health systems. I still have trouble getting the people, my family and extended family, in when we need to get in. I can't even imagine people that don't donate to health systems and stuff like that. And that's so obnoxious. But it's an amplification of what a horrible health equity problem we've got, and that's coming in part largely due to the supply and demand issues. And I think at some point that's got to become the big issue because you could move the dollars around all you want. I mean, this managed care, this Medicare disadvantage, Medicare Advantage, this, that, the other. You can move it all around. It's not the payment system.
We're on the edge of a cliff, and I'm down here in Miami, Florida. You mentioned CVS. There's 5 CVSs within a 3-mile radius of me that all have the Minute Clinic. You could 10x the provider count at every single one of those. Wouldn't be enough.
Well, and that's exactly right.
Waiting 9, 10, 12 months.
That's a good
visit in Miami. That's not.
Eric, you've nailed it. Miami's a great microcosm. Florida's a great microcosm. If you want to get a primary care doctor today in Florida, in many places, you need a concierge physician. And if you want to talk about, and a concierge physician means you're paying a couple thousand up front a year to have a concierge physician. If you want to talk about something that's horrendous for health equity, that's it. And that's not a knock on the physicians. I don't blame them one bit. That's at all. I don't blame them at all. They're working their butts off. It's a knock on what we're doing from an education producing physician standpoint. The CVS thing. So many CVSs have a Minute Clinic, but no doctors or providers in them. I mean, exactly. And so they're not really Minute Clinics. They're real estate. But yeah, I think the Florida is a perfect example of it. Growing population. To get a primary care doctor, you need a concierge physician. Is that what you're hearing in Florida a lot? Do you hear a lot about needing concierge physicians in Florida?
Oh, 100%. Many friends and family, for their children, they have a concierge pediatrician because, number one, they don't want to wait. You have a sick kid. What do you expect to do with a sick kid? You got to take them to the doctor. And if you can't just walk into a Minute Clinic, you look at the morning available appointments. There's like one appointment available at 6 p.m. tomorrow. That doesn't help my kid. You try to get to one of the big pediatric groups in Miami. Maybe they can see you today, maybe not. So the easy way out, and this is where it's going to bifurcate. You talk about health equity.
Yes.
It's already happening. It's going to be, I can pay cash. I can pay cash to retain this physician. So that's exactly what I'm going to do. I can talk to my guy or my gal now, not wait.
And it's not that you don't care about anybody else, but we got to figure out a way to solve that. It's not like you're going to do it to take care of your family. Like, I am very cautious. Like, we have relationships with lots of systems. We try to never jump the line. We try to never get special care. We do try and make sure if we have to, like, can you figure out which specialist to call, who to get to, which your ERs is more open right now. But we try to never jump the line. But you are going to want to make sure that you could actually get care for your family. And it's a real it's a disaster already if you're impoverished and not and can't afford it. And you talk about a 2-tier system, it's going to get a lot worse. And you could talk about all the Medicare Advantage you want, the different ways of managing it and stuff like that, but that's not really a solution. The solution is enough doctors and caregivers and providers and leveraging care and people working at the top of their license and all kinds of other solutions to it, and technology, but it's people and tech.
Well, I want to be greedy with your time. Just one more point that I have physicians on this show, just like I have ASC administrators, experts like you, all types of folks come on the Doc Buddy Journal. And the recurring theme with physicians, I bring up burnout. I bring up the precipice that we're on of a physician shortage. The physicians with kids tell their kids, I don't want you to follow my footsteps. Don't go into medicine. It's too much of a beating. It's not worth it. You're abused up and down. It's not rewarding work anymore. For me, I'm not a provider. I don't work in a healthcare organization. So I hear that and I kind of think, oh my gosh, if physicians are telling their kids don't do it, what hope is there for the general population to want to go into medicine? It's got to be zero.
Yeah, I think it's a complicated issue because I hear you 100%. And I know one of the children in our blended family is in medical school. And I think it's a very complicated issue because you've got this, you've got that 100%, but we've also got this situation now. 50,000 people apply to med school each year, 20,000 get in, so 20,000 go each year, something like that, around those numbers. We end up between that and medical school, DO school, 20, 25,000 a year out of 50,000 plus applicants. Of those 50,000 applicants, there's probably at least another 5 to 10,000 that don't get into any medical school. That the difference between them and the 5 to 10,000 that get in at the bottom end is probably almost nothing. You could so if you look at the 20,000 that got in versus 21,000 that didn't get in, 25,000 that didn't get in, probably the differences are probably minute. I'm not saying the person that was number 45,000 should get in, but there's still a lot of people that would like to be doctors. What we've done is we have a medical school system that is antiquated, and we could let in more doctors if we had more residency spots. That 20,000 would go to 24,000, 26,000 if those residency spots got approved. Obviously, 4,000 more residents that create 3,700 more doctors in 4 years across a nation of 330 million doesn't really solve a problem. It's still a drop in the bucket. But there are still enough people that do want to go to med school, and we need more of them. But it's different than it was. When we were growing up, of course, you went into a specialty, you knew you'd both do great work and make a great living. You'd be a bit of a kingpin in your community or a queenpin in your community. It was sort of a very esteemed life. And now it's like, it's a very different world. It's like you're just another type of professional, and it's great and it's fantastic, but it's not like it's not sort of the wife and the lifestyle and the things that sort of came with it, when we were growing up, perhaps, and so it's a complicated thing. I mean, it's all over the board. So yeah. It's a great profession. It's fantastic what people do. I mean, there are a lot of physicians that are thrilled their kids are going to med school. I'm thrilled that ours is going to med school, but it's not like it was 30 years ago where if you became this specialty, you did this, you had a great living, you also did that. It's not like, certainly not the primary care guys that used to golf on Wednesday afternoon. I mean, those days are, that used to be golf day for primary. Those days are just long gone. It's just a different world. So. Yeah, I don't know what the answers to it, but there's so many workforce shortages in healthcare that we gotta figure out a way to turn around. We gotta make it easy for people to become doctors, and not like without. I mean, it's not so much, and I don't mean this like we have a great medical education. It just is. It's antiquated. They're creating doctors in other countries that we're bringing to this country that finish it all in 6 years versus 8 or 9 years, and those doctors are wonderful. So it's very doable. They're doing it in India. They're doing it in Brazil. They're doing it in other places. They're creating fantastic doctors in 2 to 3 years less time. So it's not like it's not doable. It's being done. So,
Yeah, there's something to be said for that. And we can't lose sight of the fact that physicians go into medicine or providers of any type go into medicine because they care. They want to help people. And I have the utmost respect for a physician. But the feedback I've gotten is it better hurt you less to go through medical school, go through your residency, and become that physician, than as opposed to hurting you to never do it.
yeah,
And that balance
100%.
has changed, as you mentioned.
No, I think that's right. They want to have a great profession and a reasonable lifestyle, make a nice living, and have a great profession. I mean, both. And it's when it gets sort of like whipsawed, there's physicians that want to be entrepreneurs, there's physicians that just want to work for people, and it's constantly getting whipsawed. And it's a changing demographic, a changing world.
Well, on that note, Scott, you've been really generous with your time with the Doc Buddy show today. Is there anything else we didn't cover that you want to?
If I have enough coffee, Eric, we could talk forever, but I better let your listeners go before they all fall asleep. No, thank you so much for having me on. A great pleasure. I hope I didn't offend anybody, but what a pleasure to visit with you. Thank you so much for having me on.
Oh, absolutely. We loved it. You've got a standing invite whenever you want to make another appearance. And before you go, tell our listeners where they can connect with you, where they can get to your sites. Although a listener of this show will know exactly where they can go to get
Sure,
so where
sure.
can they connect?
Yeah, no, 100%. You could find Becker's Healthcare, obviously, online wherever. You could find me on LinkedIn, Scott Becker. You could always email me. You could message me, 773-766-5322. We love to interact with people and hear people's different thoughts. So anytime is great. But LinkedIn is easy. different email addresses you could find for me pretty easy. Becker's Healthcare, and then the text number is 773-766-5322. Thank you so much, Eric. What a great pleasure to visit with you.
We'll be sure all of those links and that text number are in the show notes. And on behalf of the entire Doc Buddy team, I want to thank you for listening. Be sure you're subscribed on Apple Podcasts, Spotify, and YouTube. And until next time, your host, Eric. We'll talk to you soon.